Welcome. Today I will talk about gastroesophageal reflux disease. Definition, epidemiology, pathophysiology, clinical manifestation, diagnosis, management, and the complications of gastroesophageal reflux disease. Before going into the pathogenesis, let's see the definition of common terms that is used with gastroesophageal reflux disease and associated symptoms. The first is gastroesophageal reflux itself. Gastroesophageal reflux is involuntary passage of gastric contents into the esophagus, and it is physiologic condition. Whereas gastroesophageal reflux disease is reflex associated with mucosal damage or sometimes severe enough to impair quality of life. So if gastroesophageal reflux causes mucosal damage or symptoms that affect quality of life, it will be gastroesophageal reflux disease. Gastroesophageal reflux itself doesn't affect mucosa or it doesn't affect quality of life. When it do so, it becomes a disease, which is called gastroesophageal reflux disease. Regurgitation is passage of reflexed gastric content into the oral pharynx and the mouth and the rolling out of the mouth, whereas vomiting is expulsion of reflexed gastric content from the mouth. Regurgitation is just drooling, whereas vomiting is expulsion of reflexed gastric content from the mouth. Rumination is in opposite to regurgitation, it is voluntary activity, whereas regurgitation is involuntary. So as we have said, gastroesophageal reflux is retrograde movement of gastric content across the lower esophageal sphincter into the esophagus. When it is physiologic, when it is just a regurgitation, it is an effortless regurgitation of normal infant, whereas when it is pathologic, it is called gastroesophageal reflux disease. In this case, there is mucosal damage, so frequent and persistent reflux is there. There is esophagitis or damage to esophageal mucosa, and even extra-esophageal presentation like respiratory symptoms or nutritional problems can be there. Just regurgitation or gastroesophageal reflux without disease occurs in more than 2/3 of otherwise healthy infants and can happen several times a day in healthy infants. Even it can occur in children and adults. In healthy adults, reflux occurs postparendal, lasts less than 3 minutes and causes few or no symptoms. The exact prevalence of gastroesophageal reflux disease is unknown, but it is generally so common in children with complex medical conditions, such as developmental delay, which can be from neuromuscular disorder or Down syndrome, and those who have history of tracheoesophageal fistula repair. Daily regurgitation is present in 50% of infants less than 3 months and in greater than 66% at 4 months. This is just infant reflux without disease. But this completely resolves by 2 years. Transient lower esophageal sphincter relaxation is the primary mechanism allowing reflux to occur. Gastric distension is the main stimulus for this transient lower esophageal sphincter relaxation. This is just a neural reflex which causes activation of intramollar inhibitory neuron, which releases nitric oxide to relax the lower esophageal sphincter. Higher frequency of this relaxation, greater incidence, and high acidity of the reflex during the reflex predispose for chronic esophagitis. Factors influencing gastric pressure volume dynamics and the position that place the gastroesophageal junction below the air fluid interface in the stomach can make reflux more likely. The frequency of reflex episode is increased by insufficient lower esophageal sphincter tone. Normally it is less than 10 at resting and more than that. But if it is insufficient, it causes reflux, and also abnormal frequency of lower esophageal sphincter relaxation and hiatal herniation presence predisposes for this reflex. The duration of reflex episode is increased by lack of swallowing, especially during sleep, and the defective esophageal peristalsis. We classify clinical symptoms of gastroesophageal reflux by age as infant, children, and adolescent, and also clinical feature which is associated with esophageal and extra-esophageal. For infants, symptoms of GERD include regurgitation and vomiting, especially postparentally. Signs of esophagitis including irritability, choking, gagging, feeding aversion, hematemesis, food refusal and irritability, and extra-esophageal. It includes apnea, stridor, failure to thrive, poor nose, obstructive apnea, stridor, and in infants usually resolved by 12 to 24 months. In children, especially in preschool one, it might present with intermittent regurgitation and vomiting, respiratory complications, decreased food intake without other complaint, which can cause non-organic failure to thrive, and Sandifer syndrome, food refusal or neck contortions. They can also complain heartburn or chest burn, just like that of adolescent and adult. Extra-esophagally, chronic sinusitis, persistent cough, impaired quality of life, otitis media, hoarseness of voice can be the feature of this gastroesophageal reflex disease in children. In adolescent, nausea, epigastric or diffuse abdominal discomfort and regurgitation, substernal squeezing or burning pain radiating to the back and resolving within minutes to hours, either spontaneously or with antacids. Usually after meals, it awakens patient from sleep and might exacerbate by emotional stress. Those age groups, they can report their symptoms as heartburn or epigastric pain or dysphagia and the like. It can cause a lot of complications, which is extra-esophageal. There are a lot of differential diagnoses for children or infant who comes with gastroesophageal reflex disease because they don't tell specific symptoms associated to the reflex. They may present with infection or sepsis-like syndrome. Those differential diagnoses include functional constipation, cow milk allergy, eosinophilic esophagitis, infective esophagitis, cyclic vomiting syndrome, hypoallergia, achalasia. They all look like that of reflex disease. To diagnose this gastroesophageal reflex disease, history and physical examination is very important. The diagnosis may be made presumptively based on clinical history alone when there is effortless regurgitation or heartburn. For infants, there is gastroesophageal reflex questionnaire. There is no single gold standard test. The investigation for GERD demonstrates consequence of the reflex events. The investigation checks or sees the consequence of the reflex, not the reflex itself. There are a lot of investigations that can be done to check for gastroesophageal reflex disease. From this, esophageal pH and impedance monitoring is one of them. This is for assessment of the frequency and the duration of esophageal acid exposure. It's indicated for assessing efficacy of acid suppression, evaluating atypical GERD presentation in non-verbal children and infants with repeated apnea. If the intraesophageal pH is less than 4, more than 10% of the time, the patient is considered to have reflux. The other is endoscopy. To determine the presence and the severity of esophagitis and its complication and to exclude other disorder, it's indicated for children with hematemesis, epigastric or abdominal pain not responding to empiric treatment, with recurrent regurgitation after 2 years and dysphagia or odomphagia. These have 25% some evidence of esophagitis endoscopy, but can be used therapeutically to dilate structure, which is caused by esophagitis. The other is barium contrast radiograph or barium esophagogram. This is for patients with vomiting and dysphagia. This is the first test used in patients with dysphagia. It is poorly sensitive and specific, but can rule out achalasia, stricture, stenosis, hypoallergia, and the like. So barium contrast radiography is to evaluate for the possibility of anatomic abnormality such as hiatal hernia, achalasia, esophageal stricture or stenosis, and intestinal malrotation. But it neither assesses mucosal inflammation nor correlates with the severity of the GERD. The other is esophageal manometer. In this case, lower esophageal sphincter pressure is expected of gastroesophageal reflex disease, but it is not specific for GERD. The other one, or the best one, or the one that all of us uses in day-to-day practices, empirical anti-reflex therapy. This is just a trial of high-dose proton pump inhibitor. Failure to respond to such empiric treatment or a requirement for the treatment for prolonged periods and mandates formal diagnostic evaluation. So once we suspect gastroesophageal reflex disease, especially in children and adolescents, without doing further workup, it's better to give a trial of high-dose proton pump inhibitors. If they fail to respond to such treatment, we go for further investigation that we have said above. When we came to management of gastroesophageal reflex disease, lifestyle changes will improve and sometimes 60% of them. Those lifestyle changes include dietary modification, such as avoid reflex-inducing foods for children and normalization of feeding techniques, volumes, and the frequency in infancy. Decrease the volume of the feeding and make it more frequent. Avoiding the supine position soon after eating, especially for infants. Promotion of salivation by giving different things that give salivation. Head of bed elevation. Thickening of feeds, especially those who are taking formula feeding and the like. In older children, avoid acidic or reflex-inducing foods such as tomatoes, chocolate, mint, drinks such as juice, carbonated and caffeinated drinks, alcohol, and also weight reduction for obese patients and the elimination of smoke exposure are the crucial measures at all ages. When we came to pharmacotherapy, proton pump inhibitors, they are the most potent anti-reflex effect by blocking the hydrogen potassium ATPase channels of the final common pathway in gastric acid secretion. Those proton pump inhibitors are superior to H2 receptor blockers. Those includes omeprazole, lansoprazole, pantoprazole, and esomeprazole. The possible complications from this proton pump inhibitor include short-term acid rebound, Clostridium difficile infection, decreased bone density, and the like. But this happens in prolonged treatment. The other is histamine 2 receptor antagonist, cimetidine, famotidine, nizatidine, ranitidine, and the like. They are a selective inhibitor of histamine receptor on gastric parietal cell. They are recommended as a first-line therapy for short-term trial of acid separation. But for treatment, proton pump inhibitors are recommended. For trial, H2 receptor blockers. Those things, if they are given for long period, they can induce gynecomastia and tachyphylaxis within 6 weeks and liver disease, but this is not common. The other is antacids. Antacid is not useful in infants, but they can be used in older children. They provide rapid but transient relief of symptoms by acid neutralization. So you can give antacid with proton pump inhibitor. The long-term regular use of antacid is not recommended because of aluminum toxicity and the risk of rickets. The other is prokinetic agents, including metoclopramide, betanacol, and erythromycin. Most of these prokinetic agents increase lower esophageal sphincter pressure. Some improve gastric emptying or esophageal clearance. None affects the frequency of transient lower esophageal reflex, so they are not as such recommended in pediatrics. Regarding duration of treatment, in adults with true erosive esophagitis, mucosal healing with proton pump inhibitor can take up to 2 months. So for mild esophagitis, we can give for 2 weeks. For those who have severe signs and symptoms, we can give for 3 to 6 months. In addition to this, proton pump inhibitor lifestyle modification is very important. The final one is surgery. Anti-reflex surgery is most often considered for patients with recurrent pulmonary disease from aspiration of reflexed material, failure to thrive that does not respond to tube feeding, intractable esophagitis, and stricture that does not respond to proton pump inhibitor. Fundoplication, or the gastric fundus is wrapped around the distal esophagus, is the most common surgical technique. This is associated with significant morbidity, so it is reserved for those who have severe gastroesophageal reflux disease who have a lot of complications. When we came to long-term complications, the first one is asthma. Gastroesophageal reflux is common among patients with asthma, and it is an established trigger of asthma. Reciprocally, respiratory symptoms may provoke gastroesophageal reflux. Gastroesophageal reflux can provoke asthma. Asthma can also provoke gastroesophageal reflux. There are two mechanisms proposed whereby gastroesophageal reflux disease may produce bronchoconstriction. Those include, the first is increased vagal tone or gastric asthma. The other is, during reflux, there is microaspiration of gastric content. But it does not indicate which patients with asthma are likely to benefit from anti-gastroesophageal reflux disease therapy. So, if asthma symptoms during an episode of reflux and the use of inhaler when feeling symptoms and the nocturnal asthma, we should have to consider reflex in a patient with asthma. In about 60% of children with asthma and evidence of reflux, asthma control will improve with treatment of reflux. So, if asthma symptom is difficult to control and it is mainly nocturnal, a 3-month trial of proton pump inhibitor are recommended. The other is recurrent pneumonia, and the failure to thrive because of calorie deficiency can also occur, and the patient may come with just failure to thrive because of recurrent vomiting and esophagitis that precludes oral intake. The other common complication is esophagitis, which occurs in 50 to 60%. They manifest as irritability and feeding aversion in infants and epigastric pain and dermatitis in children. Prolonged and severe esophagitis leads to distal esophageal stricture. This causes metaplastic transformation, which goes for Barrett esophagus and which is a precursor of esophageal adenocarcinoma. Barrett esophagus is a precursor of adenocarcinoma. This is due to chronic esophagitis. In addition, reflux can cause dental erosion on the lingual surface of the teeth. This is all about gastroesophageal reflux disease. Thank you for watching.